Today we are going to talk about the supraglottic and the supraglottic swallow, which are techniques that utilize components of airway protection mechanisms to facilitate safe swallowing for some patients. I will talk Drell through completion of the maneuvers. We are going to begin the supraglottic swallow. Drell, are you ready?
Yes.
Take a breath and hold it. Now take a sip of your water and keep it in your mouth. Now swallow while still holding your breath. Cough. Swallow again. Exhale and relax. Great. Now Drell is going to demonstrate the supraglottic swallow. Take a breath and hold it. Now take a sip of your water while keeping the water in your mouth. Bear down with your arms on the surface beneath you. Now swallow while still holding your breath. Cough. Swallow again. Exhale and relax.
Although we used water in our demonstration, you can execute these maneuvers using saliva, which is a safer option for medically fragile patients or patients who have a history of aspiration.
So why is this maneuver helpful? The purpose of the technique is primarily for airway protection through glottal closure and laryngeal excursion. This is a three-step process that involves 1. Holding your breath for vocal flow deduction, 2. Coughing to propel any part of the bolus that entered the airway, and 3. A second repeat swallow to clear any remaining residue on the larynx or at the entrance of the airway.
Before recommending these techniques, administer an MBS or FEES to observe airway protection during swallowing. These techniques are recommended if imaging reveals the patient to have decreased laryngeal vestibule closure, residue in the piriform sinuses, poor superior movement of the arytenoid heads towards the epiglottis, and or post-cricoid spillage of residue into the laryngeal vestibule closure.
It is important to note that because coughing is a critical step of the maneuver, patients must have effective volitional cough to eject penetrated or aspirated materials. This is not safe for patients with respiratory conditions because of their limited ability to hold their breath during swallowing, as required by the maneuver. The patients also need to have the ability to bear down or pull up to create tension necessary to execute the supraglottic swallow.
Now we will talk about evidence supporting the use of these maneuvers. A study was conducted by Fujiwara et al. To evaluate the state of tongue pressure production during supraglottic swallow and supraglottic swallow performed by healthy adults and to investigate the effects of these swallowing maneuvers on the oral stage of swallowing. 19 healthy individuals were asked to swallow 5 milliliters of water via normal wet swallow, supraglottic, and supraglottic swallow. The parameters for analysis were the duration, maximal magnitude, and integrated value of tongue pressure during swallowing. Results revealed that duration of tongue pressure was significantly longer at the anterior median part of the hard palate during both supraglottic and supraglottic swallow than with normal wet swallow. The maximal magnitude and the integrated value increased significantly at the posterior part of the hard palate during supraglottic swallow but at all points during supraglottic swallow. These findings imply that both supraglottic and supraglottic swallow, which are known primarily as techniques to protect the airway, also function to strengthen the tongue pressure produced by the contact between the tongue and the hard palate during swallowing.
Another study written by Takashi Kashara et al. Aimed to assess the effectiveness of the supraglottic swallow as an indirect exercise to retrain the breathing pattern during swallowing and to change hyoid bone movement. The study was conducted on 10 healthy volunteers without a history of dysphagia using video fluorography. Some patients were told to swallow normally, which was the control, while some were told to use a supraglottic swallow maneuver. Results found that the maximum superior and posterior excursion of the hyoid bone was significantly larger with the supraglottic swallow group than with the control normal swallow group. There was no statistical difference for the anterior movement of the hyoid bone between the two conditions. The patients who used the supraglottic swallow technique were also able to maintain the movement of the hyoid bone for a longer period of time. This indicates that the supraglottic swallow maneuver is effective as an indirect swallow exercise and has implications for clinical use. Not only can it be used for airway protection, but it can also be used to strengthen the muscles attached to the hyoid bone, expanding its range of motion.